We'll shift gears a little bit too, also to unresectable non-small cell lung cancer. Now, sometimes patients present with a diagnosis of non-small cell lung cancer, and for any number of reasons, it is felt to be not able to be surgically resected. And that could be, lung function status, the extent of the disease, personal preferences, logistics, any number of reasons. But in this situation, patients can still be offered curative therapy with what we call definitive chemoradiation, or chemo-RT is what you'll hear us refer it most commonly as. So the Pacific study, and I apologize for the typo there, really had set the standard for us for how to treat these patients with unresectable stage 3 non-small cell lung cancer, because in this study, they took patients who had stage 3 non-small cell lung cancer, received definitive chemotherapy and radiation, most frequently given together. And if they had no evidence of cancer progression at the end of this, patients were then randomized in a 1-to-1 fashion to receive durvalumab, which is a type of immunotherapy, or a placebo for up to a year. And patients must have had their first dose of durvalumab within 42 days of completing the chemo and the radiation. And then patients were followed closely, like all studies, with scans continuously. And cut to the chase, this has been approved since 2018, but we are happy to see that even as the data matures, at 5 years, there is a continued improvement in overall survival with durvalumab of 42.9% compared to 33.4% with placebo. So this has been the standard of care for some time now for these stage 3 patients. But the important question has been asked, does this apply to all non-small cell lung cancer, or in this instance, should we also be looking at molecular subtypes? Now, I will say that when the Pacific study was first initiated, we didn't know that as much about EGFR and ALK and all these other subtypes. And so these patients were not specifically excluded from the Pacific study. And so what this Dr. Naidu and her team did is they went back and they looked at patients who were on Pacific who had an EGFR non-small cell lung cancer, and they wanted to see in this subgroup, did patients benefit from durvalumab? You can look at the progression-free survival curve on the left, the overall survival curve on the right, and you'll see that it's pretty clear from these two graphs that is, overlapping, that there not seem to be a benefit of the durvalumab in blue versus the placebo in yellow. And so if you're thinking about therapies, if there really is no benefit in controlling the cancer or living longer, there probably is no benefit of this drug at all, because the negative side, of course, is that there's going to be toxicities that you will be incurring. And so here comes the LAURA study, which is patients now with this locally advanced unresectable stage 3 EGFR non-small cell lung cancer, again with sensitizing EGFR mutations. They must have received definitive chemoradiation. This could have been done concurrently, so given together, which is the most frequent way that we do it, or sometimes sequentially with chemo first followed by radiation. Much like the Pacific study, they had to have no progression of disease after definitive chemo and radiation, and they must have started the study within 6 weeks of finishing the chemo radiation. In this study, patients were randomized now in a 2-to-1 fashion to receive osimertinib 80 milligrams once a day indefinitely, or placebo, or nothing, surveillance. And patients, again, were continuously assessed. Importantly, they were also assessed with CT scans and MRI brains, because again, brain metastasis is a frequent occurrence in non-small cell lung cancer. And even in an earlier stage, it is incredibly important to keep on looking at the brain and monitoring it. So here we saw the results of the progression-free survival. This was presented by Dr. Ramalingam this year at our ASCO meeting. And it is very clear to see that osimertinib led to an impressively improved progression-free survival as compared to placebo. You see the median progression-free survival with osimertinib was just shy about 40 months, with placebo is just about 6 months. Again, we don't have the overall survival data yet. That is still maturing. But I think, this level of benefit was strong enough for the FDA to also approve osimertinib for patients with unresectable non-small cell lung cancer with EGFR sensitizing mutation after definitive chemotherapy and radiation.